Live from Borges Medical Center in Kalamazoo, Michigan, this is a live internet webcast demonstration of the placement of the recently FDA-approved Cypher stent. Today, Dr. William Campbell, Medical Director of the Borges Cardiovascular Laboratory and cardiologist at the Heart Center for Excellence, will perform the stent procedure, along with the assistance of Dr. Michael Lauer, Associate Director of Cardiovascular Research and Director of the Angiographic Core Laboratory at the Borges Heart Center. Dr. Tim Fischel, co-inventor of the flexible yet strong platform used for the drug-eluting stent, will be your host, and he will answer your email questions about the procedure. Dr. Fischel is also Medical Director of Cardiovascular Research at the Borges Research Institute and a cardiologist at the Heart Center for Excellence.
Well, the Cypher stent, in my opinion, is a breakthrough technology. This is a technology that deals with a problem that we've been trying to solve for more than 20 years, the problem of reblocking a blood vessel, a coronary blood vessel, after it's been treated with a balloon angioplasty or a regular stent. With the Cypher stent, rather than having a reblockage rate of, say, 15 or 20%, which would be the typical bare stent, we're looking at a reblockage rate requiring retreatment in the range of 1 or 2%, about a 10-fold improvement over bare stents.
Like coronary angioplasty, the Cypher SirolimusCoated Stent may dramatically change cardiac care. Coronary angioplasty has been a giant step for coronary artery disease treatment for the past 25 years. The minimally invasive procedure uses a balloon to widen narrowed arteries. Since the advent of the stent, a small expandable wire mesh tube used to hold the artery open, restenosis or re-narrowing of the artery has been its major flaw. With drug-eluting stents, this drawback will be largely removed. The result? Some experts believe the coated stent and other minimally invasive techniques will reduce U.S. coronary artery bypass graft surgery cases from about 550,000 cases annually today to about 300,000 cases by the year 2010.
The people that are going to benefit the most are hopefully the diabetics, of which we're seeing so much of nowadays, the areas of long blockage that previously we would frequently send to surgery. You know, those are the people I think will benefit the most. But I think in the near future, everybody is going to be getting some form of, chemically coated stent.
Today's webcast will be made available for continuing medical education credit to qualified physicians. Now your host, Dr. Tim Fischel.
Welcome everyone to Borges Medical Center in Kalamazoo, Michigan, where we're very pleased to present a live case of a Cypher or drug-eluting stent implantation from the Cardiac Catheterization Laboratories here at Borges Medical Center. We're going to present some information about this device and why we think this is a big change in cardiology. And we're going to start first by introducing the expert team that we've assembled in the Cardiac Catheterization Laboratory to perform the procedure today. On the right of your screen is Dr. William Campbell, the Director of the Heart Center for Excellence and Director of the Cath Lab. Bill, welcome.
Hello, Tim.
We have Dr. Wada Salman at his side there, who's one of our expert interventional cardiology fellows. And on the left side of the screen there in the red lead is Dr. Michael Lauer, one of our experts researchers and an expert in intravascular ultrasound, who's going to help to explain some of the images that we see inside the blood vessel today. I also want to acknowledge our Cath Lab staff, who are some of the best in the country. Standing behind Dr. Salman is Kim, and we also have Chris and some of the nurses in there. I can't see everyone who's in there today, but we have some terrific technical staff helping out. We're going to come back to the Cath Lab in just a minute, but I'd like to introduce for the audience the concept of this drug-eluting stent and the reasons that we need this technology to help patients. On the screen you can see a blocked artery on the left. Now this is a typical kind of a blockage inside a heart artery that causes chest discomfort. Now today, with the contemporary stents that we have, it's actually quite easy to repair this type of blockage without open heart surgery by using what's called a stent or a metal scaffolding. And you can see that quite simply on the right, a stent has been placed. This metal scaffolding is expanded out into the blood vessel and pushes away the blockage of atherosclerosis, leaving this open vessel. The patient can go home the following day. So this is a relatively simple procedure. And so I ask the rhetorical question, as do many cardiologists, if stents are so good, then what's the problem? And one of the biggest problems that we have today is a problem called restenosis. This is a reblockage within the stent caused by scar tissue. And indeed, in very simple blockages, very short areas of blockage in big vessels, the reblockage rates are low. In longer blockages, in diabetics, and in smaller vessels, the reblockage rates are actually quite high. And for the patients who suffer from reblockage and chest pain again after a procedure, certainly any level of reblockage is too high. What does this look like? Well, this picture that you see shows in the top panel a very good result after a stent has been implanted to open a blocked artery. About 3.5 months later, this patient comes back in with recurring chest pain, chest discomfort, and we took a picture and you can see what restenosis or reblockage inside a stent looks like. In this case, you can see just a thread of an opening inside the blood vessel where it used to be big and black with blood flowing. Now there's a tiny thread. You can see the shadow of the stent, and the stent is now virtually filled with scar tissue. This happens about 15 or 20% of the time with all of the contemporary stents that don't have drug. And so our ideas have been, as interventional cardiology community, how can we solve this problem? This is what the blockage looks like. If you look at the pathology of what a blockage in a human artery looks like, you can see on your left screen the little black dots are the cut pieces of stent, and inside that, the purple tissue, the purple material you see there, is the scar tissue that's grown inside the stent and reblocked the opening. All that's left now is that little white opening, and on the right side you can see what this looks like grossly with the stainless steel stent cut. And I think my friend who I trained with, Dr. Paul Tierstein, out in California, probably had the best quote in a recent editorial when he likened this problem to surgery. When he says, when a surgeon removes a gallbladder from a patient, he doesn't expect it to grow back. And that's the way that I've always felt, and my colleagues, I think, have felt as cardiologists, that when we fix a blocked artery, it really hurts us and hurts the patient when we see the stent that looked so good reblock, and we have to start all over again and try to figure out ways to treat that, including the need for bypass surgery. So this evolved into a variety of concepts to stop the reblockage, and the most effective one, and the one that we're talking about today, is the one of putting a drug on the outer surface of a metallic stent, and the drug then can target the drug delivery right into the blood vessel wall without having to give high doses of the drugs with pills or intravenously. This minimizes the toxicity of such a drug and allows us to release the drug in a controlled fashion, say over 30 or 40 days, which is the time course for initiating the scar tissue that forms after the injury from a stent. This is a list of the kinds of blockages that have a high rate of reblockage that we need to improve our outcomes for. Long stents and small stents, left main arteries that are sent to bypass typically, we would stent those if the stents didn't reblock. Bypass grafts that are diseased, that are old, chronic occlusions or CTOs, bifurcations where vessels branch, and other patients such as diabetics, patients with multi-vessel disease, SFAs, a blocked leg artery, kidney arteries, carotid arteries. As you can see, the list of places where we put stents that reblock is very long, and this is a very big problem. We're finally getting a handle on this with this new technology that's just been approved. The drug that's been put on the outside of the stent is a rather remarkable drug. This drug is called Sirolimus. The old name of the drug was rapamycin. Sirolimus is the approved generic name of this drug, and it's sold by Wyeth Ayers for the prevention of kidney transplant rejection under the name Rapamune. This drug, over a 5 or 6 year period of testing, both before using it in patients and now for many years tested in patients, has been now launched as the FDA-approved product called the Cypher sirolimus-eluting stent, which is manufactured by Johnson & Johnson, and that's the device we're going to look at today. How does this work? Well, this is a somewhat complex slide that I'll try to simplify for you, but this is a depiction of a cell inside a blood vessel wall after an injury from a stent, and you can see these colored growth factors on the surface of the cell, PDGF, FGF, and a variety of other growth factors bind to the cell and stimulate the cell through this TOR protein, stimulates the cell to divide and to make new scar tissue and to grow new cells inside the stent. Where does sirolimus fit in? Well, sirolimus, shown here in the red box, binds to a protein inside the cell, and this complex then binds inside the cell to this protein called TOR, and this blocks it, and it blocks the messengers that tell the cell to proliferate, thereby preventing scar tissue from forming. It also is a very potent anti-inflammatory drug that keeps the white blood cells away from irritating the struts of the stent. How does this look on a stent itself? Well, it's put on with a very thin coating, about half the thickness of a red blood cell, and you can see in this picture a picture of a stent that's coated with the drug, and you can see a real picture of the stent that has the drug coating on the right side, and you can see that it is a very, very thin coating. That's the stainless steel stent shown at very high magnification with a very thin layer of this polymer that contains the drug. Over about 30 or 40 days, it releases the drug into an artery, and you can see in this picture from an animal experiment done years ago that the control stent, or the stent that does not have the drug, has quite a bit of scar tissue inside the black dots. And you can see that pink material is the scar tissue. And on the right, you see a stent that has the sirolimus. And you can see very little scar tissue inside the stent. Interestingly, although animal type of studies like this don't always predict the human responses, we are very gratified that the responses in patients have been just that good. How good? Well, here's a picture of a case from one of the first implants in patients from Brazil. On the upper left, you can see a severe blockage in the front artery. The stent has been put in the upper right picture, and 4 months later, a picture was taken showing that the stent looks pretty much exactly like it did the day it was put in. 1 year after the stent was put in, the stent again looks just like it did the day it was put in. And these results are remarkably reproducible, with about a 95% average inhibition of scar tissue by this drug. Quite a remarkable drug. How does it look? This is a graph showing the first-in-man experience. The red line is the line to focus on here, and that shows the minimum opening within the stent at different points of follow-up. And you can see that this vessel started at about 1 millimeter in diameter, and after the stent was put in, it was 2.9. And then 4 months later, it was 2.8. A year after the stent was put in, the opening was 2.8. And at 2 years, it actually, within the error of measurement of this angiogram, was about the same at 3 millimeters. So there actually is, over a 2-year period in this particular set of patients, no late loss, no scar tissue formation detectable from the angiogram. This is the kind of result that we would love to see in bigger trials. And indeed, larger trials have been done. The Revel trial, which was done in Europe, was a randomized study with 120 patients who got a regular stent and 120 who got the drug stent. And you can see in the blue, the left side, there was 1 death with the regular stent, but there were 23% of the patients who got the bare stent who needed another treatment, whereas 0 out of 120 patients who got the drug stent required another treatment at a 1-year follow-up. This is really remarkable, to reduce the reblockage rate from 23% down to 0%. Similar results have been seen in the U.S. trial in a much higher risk group for reblockage. And you can see the results if you look at the lower right hand, that 3 out of 697, that is the number of stents that have blocked so severely that they required another treatment between the first-in-man trial, the Revel European trial, and the United States trial. Out of 697 patients, 3 of them had blockage within the stent itself that required a treatment. Now, some patients had some blockage outside the stent, but within the stent failure rate was less than 1 in 200, a remarkable result. What does it look like in the United States? Well, this is one of the cases from Borges, And after this, we'll go to the live case. But this shows you the kind of blockage, a long blockage in the upper left corner. And then after 2 stents were placed in the upper right, we then brought the patient back for a picture at 8 months follow-up. And you can see that the stents that were put in look just the same 8 months later. More importantly, we looked with a camera inside the vessel. And you'll see this live in a minute. During the implant, you can see the white dots on the lower right picture. Those are the stent struts of stainless steel, and we're looking for white material within those little white dots. That would be the scar tissue, like I showed you from the pathology pictures, and we don't see any scar tissue within the stent 8 months after the implant, either from the angiogram or from the camera that's put inside it. So these are really quite remarkable and reproducible results, and we'd like to now demonstrate, go live to the cath lab, and show you what this type of procedure looks like. So let's go to the cath lab, and Dr. Campbell is going to introduce the patient who's kindly volunteered to participate and have his vessel treated for the webcast, tell us a little bit about the patient, and then explain a bit what we're going to be seeing today live.
Thank you, Tim. Right now we have a very cooperative 67-year-old patient. Perhaps you can hear him snoring in the background. The history, basically approximately 30 days ago, while walking along the shores of Lake Michigan with his dog Fluffy, he developed discomfort in his chest, a precordial pressure, and it radiated either side of his neck into his left arm. Had some associated shortness of breath. First episode lasted about 5 minutes, went away when he stopped. Since that time, he's noted recurrent episodes of similar type of discomfort. He saw his family physician. Family physician went over his risk factors, which included diabetes, high blood pressure, smoker, high cholesterol. Family physician ordered a stress test. The stress test was markedly abnormal at 3 minutes on the treadmill. And thus he was referred to Borges. We, at that point, talked to him, and naturally, with the risk factors and the abnormal stress test, scheduled him for a heart cath. We've started the procedure already. At this point, we have introduced a sheath into his femoral artery. We have, through that, already taken some pictures, and we have a catheter which goes to what is called his right coronary artery, supplying the bottom wall of his heart. And I would like to, we have to take some further pictures to well define the lesion. Lesions are not always concentric, but often very eccentric. And so with that, we're going to take a picture in what we call the LAO projection. I'm going to flush, please, a little dye. Okay, we're going to manipulate the catheter into the vessel.
So Dr. Campbell, what you can see is the shadow of that guiding catheter, and he's just introduced it into the opening of the right artery, and they're going to inject this contrast material and take a picture and show us what this blockage looks like.
So here's a picture of that vessel in one view. I think the lesion or the narrowing is pretty obvious.
So you can see it's right before that little branch that comes off. You can see what we would probably call about a 70% diameter narrowing. And the cross-sectional area for that, we would usually estimate, if it's 70% blocked by diameter, that about 80 or 85% of the cross-sectional area of that vessel is blocked with plaque.
In a second view, from the right, same vessel. Again, the lesion is well defined in the proximal portion of the vessel, or the beginning of the vessel. This is the most common area for blockage. It does not look as severe in this particular view as it does in the other. To better define the blockage, we're going to be looking at it with intravascular ultrasound. And to do that, we advance a very tiny little wire down the vessel, which we also use to guide the balloon and the stent. The wire itself is 0.014. We've
that's
already
like 14 thousandths of an inch.
We've already put a little bend on it. And we'll introduce this wire. I'm going to move the camera back in the other view. I demonstrated the vessel better. And we slowly feed the wire up. This catheter does have side holes in it. When we originally put the catheter into the vessel, there was some spasm. So we changed for a catheter with side holes to let the...
So you just had to steer that wire away. Dr. Campbell now has a little, what's called a torquer that he has on the back of the wire, and having put a little bend on the end of it, he can turn the wire down outside the body and then steer it, as he's doing so skillfully there, right through the blockage. Having Dr. Campbell's been doing this for a long time, so he kind of knows where to point it. He doesn't even need much direction from the contrast injections, but he's going to be steering that. He's already steered it through the blocked area, and he's going to park that wire down below in the bottom part of this right coronary, as he's already done. So now you can see that wire is way down in one of the branches, way past the area of blockage.
So our first few pictures we use as a road map, and we can easily compare the bend of the wire, the bend in the wires that it takes as it goes down the vessel to the road map, and manipulate that wire. The advent of the wires, I think, were the second major, after the balloons initially came out, the advent of the wires really made quite a difference.
It's fair to say that the technology that we have today in 2003 is really remarkably better than what we started with 15 or 20 years ago, when we had rather poor wires, we had no stents, we only had balloons, and they were kind of big and bulky. So all of the equipment has really improved, including the piece of equipment that we're about to see now, called an intravascular, or inside a blood vessel, ultrasound imaging catheter. And Dr. Lauer is one of our experts in intravascular ultrasound. Dr. Campbell, why don't you show us the camera? This thing is quite remarkable. It's less than a millimeter.
The camera, we slid it over the wire, so the wire goes right through the middle of the camera. This is a guide marker for the very tip. The camera itself, I shouldn't have really said it went through the camera, but near the camera. The camera itself is this marker. And we're using this to judge the length of the lesion, basically the size of the vessel. So I'm going to slide that camera down this wire now.
So this is really pretty remarkable technology, where we have a camera that takes pictures with ultrasound. It sends out sound waves, and then it bounces off the blood vessel wall, and based on the timing of that signal coming back, creates what's called an ultrasound image. Any of the women who've been pregnant and had babies have undoubtedly used seen the same technology used to look at babies in the womb, and the same technology has been miniaturized now to the point where we can slide it over a 14,000th of an inch wire in a camera that's less than a millimeter wide, and take a picture inside the artery of a patient's beating right coronary artery on the outside of his heart, which is what we're doing right now here.
The approach with the Cypher stents is really, it's different than what we've had, in that we try to stent from normal tissue to normal tissue. Prior to this, we were trying to just do the lesion itself, and it was always the less metal the better. Things now differ.
So what are you seeing there, Bill? Can you explain the fluoroscopy picture that we're seeing?
We have the wire down, and we've just advanced the ultrasound. You can see the tip of it. The camera itself is now just sliding through the blockage, and we've advanced it beyond the blockage. I
think that's a good position there. So basically, we have a camera now down inside the vessel, and Dr. Lauer is going to take over for us, and as we set this thing up, we do what's called a pullback, where the camera is going to be pulled back slowly at a uniform speed through the blockage, and we're going to hopefully get a nice image of what the plaque buildup looks like inside the artery. It's like a fantastic voyage, looking inside this patient's artery, looking at the plaque. Michael?
Right, Tim. Here we are in the camera is now distal to the lesion and distal vessel, and we can see on the screen here is that in the middle of the camera is a large dark area, which is actually the outline of the camera. The markers on the screen, the small green dots, represent 1 millimeter demarcations, and we see that the circle in the middle is the camera itself, surrounded by some white ring down. The large area that's kind of bouncing back and forth, the gray speckled area, is the lumen of the artery. And we can see a nice clean artery wall outside that. If we're going to go ahead and start the pullback now, and the catheter and its camera will slowly pull back inside the artery, and we'll see plaque developing on the outside. So now if we start about 1 o'clock on the artery wall, and down to 6 o'clock, we see some plaque develop. There's a thin rim of calcium, very bright. If we go to live feed now, I'll just show with the cursor on the screen. Now we see a large area of concentric atherosclerosis building up in the artery. I've kind of put a split screen now. The cross section in the upper left-hand corner we see, and we see the artery being laid out in long view in the bottom right-hand corner. If you step on floor just for a minute.
Now there's the blockage right there.
Yeah.
See how it's getting very narrow?
Very narrow.
Right there. It's almost
Absolutely.
completely around the camera there, Mike.
Exactly. We'll make some very detailed analysis and measurements in a moment. But as Tim said just a moment ago, you could see the artery almost shrink down around. It was barely bigger than the 1 millimeter ultrasound camera in the artery. We're now proximal to the lesion. We're going to go ahead and continue the pullback for a while so we get a nice, good section of healthy vessel proximal to it. We'll go ahead and complete it all the way back to the ostium of the artery. We see there's a little bit of buildup of plaque here, proximally, not quite as severe as we saw more distally. And that was the reason when we first put the catheter in, there was a little bit of spasm in that area.
It's always remarkable to me, Mike, and to people who have been doing the intravascular ultrasound, that even areas that look pretty darn good on the angiogram, they don't look blocked at all, have often quite a bit of atherosclerosis, as you just saw there. The top part of this fellow's artery didn't look too blocked, but we saw all that buildup material inside it.
Exactly. Actually, we've done, during research studies, they did intravascular ultrasound on young healthy individuals in their 30s, 20s and 30s with no apparent atherosclerosis, and you can see some very silent atherosclerosis building up in the artery wall long before it's evident either clinically or on the typical angiogram.
Now, Mike, did you get a measurement for us to give us an estimate of how big this vessel is?
Absolutely. First, I'm going to go to the area where we had the most severe stenosis.
That's a good frame right there.
It's about there. We're going to make some measurements here. The computer put down a first edition. I'm going to modify that a little bit. Actually, the artery wall on the outside. We'll try that one more time.
Yes.
So this thin black band represents the outside of the artery, the elastic membrane that surrounds the outside of the artery. And I've got that edited to the point. And this gray interface here that comes down right around the camera represents the actual lumen of the artery.
So the outer orange line is sort of how big the vessel should be, and that inner orange circle is how big the vessel really is in terms of the area for blood flow. Is that correct, Mike?
That's correct. And now we've laid some measurements across, and what we can see is the diameter of the inner area, the lumen area, is about 1.9 by 1.7 millimeters, giving an area of 2.5 millimeters square. The artery itself, the outer green line, is 4.3 millimeters by 3.7 millimeters with an area of 12.1. So we can see this is a severely stenosed artery with an area less than 4 is considered significant in a large epicardial artery like this. So this is clearly although the angiogram looked to be moderate to severe, is a very severe lesion. We're going to save these. I'm going to make a couple more measurements, proximal and distal to the artery. I've now moved the camera proximally. If we look on the bottom of the screen, we've now laid out the artery from distal on the right to proximal on the left, and I've moved the camera, the white line here that I can move with my cursor, up to an area where that band of atherosclerosis has now disappeared. And now we can once again make some quick measurements, and we see that proximally the artery is again about 4 millimeters in diameter. We'll save those measurements and move downstream to again an area that is free of atherosclerosis, because as Dr. Campbell mentioned, we no longer want to minimize the length of stent, but what we want to do is go from healthy vessel to healthy vessel, because there's a little bit of trauma at the edge of the stent, and what could happen if there is some trauma in an area outside the stent where there's no drug, we could potentially have some re-narrowing there. And since the risk of narrowing inside the stent is so low, we want to make sure we have no edge trauma to deal with. So now we're going to make some measurements at the distal aspect of the and we see again it's about a full 4 millimeter artery.
So this is a pretty big vessel, and we are limited right now in terms of the sizes available of stents, the diameters of the drug-eluting stents. Right now we only have up to 3 millimeter diameters, but these stents can be expanded a little bit larger than that, up to perhaps 3.5 or even 4, and that's what we're going to be looking at doing probably in this case, now that you've told us that this vessel probably should be 3.5 to 4 millimeters.
Right. If you look back, if you still see the screen, Tim, I've now laid out this green line on the long view of the length, and the length between the two reference vessels from healthy to healthy is about 25 millimeters in length. So we'll probably, Bill, want to use a stent that's at least that long, somewhere between 23 and 28, I would suggest 28 millimeters, to make sure that we cover this area from healthy to healthy.
This is a very important point, as Dr. Lauer is pointing out. In the old days, we used to balloon, injure a lot, long areas, and we used to put in very short stents, which we used to call long balloon focal stenting or spot stenting. And with non-drug-eluting stents, that's a pretty good strategy, and the results are reasonably good. However, since these stents themselves with the drug have virtually no reblockage, we're now changing to a strategy of putting in somewhat longer stents, and if we do have to dilate the vessel, staying totally within the stent and using short balloons. So we've gone from long balloons and short stents to long stents and short balloons. Sort of changed our philosophy about how to maintain the opening in these vessels. So I think you're right, Mike. 28 millimeters looks like just the perfect length. These stents come in 13, 18, 23, and 28, and 33 millimeters. And I think, as you point out, 28 millimeters is the closest match to the length that matches this fellow's blockage. Bill, do you agree with that?
I agree. As opposed to previously with long stents, I believe it's 13% restenosis for every 10 millimeters of stent. And with the Cipher stent, the figures that I read were 1.6% for every 10 additional millimeters. So definitely the sirolimus is making a major difference. And I know in peripherals as well, we're doing the same thing. We're going from normal to normal in the superficial femoral. Unfortunately, it's not yet, the sirolimus is not yet available for the peripheral, but has made quite a difference going from normal to normal. Right now,
You getting the stent? Let me answer a couple of questions. We had a couple of questions come in by email, which I'll answer while you're getting the stent prepared for entering into the body. Someone asked the question, what factors determine whether a patient receives a stent or has open heart surgery? And that's a very good question. The answer is that now that we have the drug-eluting stents, I think many patients who historically would have been referred for bypass surgery now can be treated with results that are comparable to or perhaps even better than bypass, even if they have 2 or 3 blockages. In the past, if you had 3 or 4 blockages or some severe blockage in a long area of blockage in one of your vessels, many cardiologists quite reasonably would be recommending bypass surgery, especially in diabetics. Now that we have the drug-eluting stents, I think we're going to transition about 20 to 30% of the patients who historically would be getting bypass to get stents. So that's going to be one of the big changes. In terms of recovery time, one of the other questions was how long does it take to recover? The answer is after the stent is put in, this fellow will go home tomorrow morning and he could be walking his dog on Lake Michigan or riding a bicycle probably tomorrow afternoon or the day after. So the recovery from this is basically, it's almost outpatient surgery. You go home the next morning, typically. So I'm going to just try to get through a couple of the questions there. Bill, you ready to show us the stent?
The stent is now mounted on the wire. The wire, you can see, the stent goes from here to here. It's in its obviously collapsed stage. A balloon sits inside the stent.
That's a nice
and
picture of it.
the technology is unbelievable, considering the size of the stents and the strut structure. So now I'm going to advance the stent down the wire. And we're going to go on to fluoro.
So we call this a guide wire, the wire that you see that the stent is tracking over, and that's a pretty good name for it because it helps to exactly guide the stent inside the correct path into the blocked artery and into the blockage. And so now we see the live fluoro image. The wire is downstream. That dark snake-like thing you see down there is the end of the guide wire down inside the right coronary artery. And then we'll see the stent coming out of the guiding catheter probably momentarily. And then Dr. Campbell is going to position this stent right in the exact position to cover the blocked area, have one end of it in one of the more normal areas of the vessel, and then the other end sitting in the other more normal, and thereby get the whole vessel treated. There's the stent. You can see it's a pretty long stent by traditional standards. We don't worry as much about the length of the stent since that's not a big predictor of reblockage anymore with this device. And we have it there. That's a pretty good position. What do you think, Bill?
We're going to take a picture with the stent. You can see the stent right now. It's the two markers. The stent sits between the two markers. We're going to document with a picture with a little dye if we have it in good position.
Can we see the fluoro there?
And let's... Okay, do you want to flush it a little more dye, please? It looks pretty good.
I think it needs to go further, a little bit further, I think,
Actually, Bill, I was reanalyzing the IVUS while you were positioned that, and I spun the view around a little bit. If you want to take a quick look at the IVUS screen, there's actually the severe area that we all saw, but then there's some moderate disease downstream, which I think we're seeing about where the end of your stent is now. So we're going to want to place that stent cutting the proximal edge fairly close, but give our extra stent kind of downstream, if we will, make sure we have this other area of moderate disease more downstream.
That's a good point.
The severe lesion is not necessarily, it's not centered. The most severe portion is towards the beginning of the lesion.
Okay. Can we see the live fluoro?
So,
See a little test there.
Yeah, it looks a little.
another test, please.
Now Dr. Campbell has advanced the stent. We easily cover now that proximal area of severe stenosis as well as the more distal area of moderate stenosis, where we don't want the edge of the stent landing in that area of moderate stenosis and causing edge trauma. So it looks like we've got it pretty covered there. What do you think, Bill?
It looks pretty good. It looks pretty good. We're going to now inflate the stent. The one thing about these stents, you have to inflate them to an adequate pressure. They should be inflated at least to 15 to 18 atmospheres.
You could see that waist on the balloon as you were inflating. That was a pretty nice angiogram. I don't know if we can replay that, but what you'll see as the balloon is inflating. Did you record that on Cine, on a digital loop?
We did.
Why don't we replay that digital loop and look at that balloon sort of pops open right where the blockage was.
We now have the balloon inflated to 18 atmospheres of pressure.
Step off fluoro. I think we can. Here we go.
So there's the balloon being inflated. You see that waist on the balloon? You can see it sort of opens at the top and the bottom of the balloon, and then that's where that severe blockage was. You can see it took a little while for that to open up. Now, we have the impression that this stent, which has only been expanded probably to a little bit above 3 millimeters based on the delivery system that it was put in with, that we probably need to expand that a little bit bigger. Do you agree with that, Bill?
I totally agree. Totally agree with, especially with the IVUS measurements. So we've deflated the balloon. Again, we've left the wire down the vessel.
I don't know if the audience can see it, but you can see a little bit of a shadow of the stent. The stent is somewhat visible inside the vessel now. It's been deployed. It's been pushed up into the vessel wall by the balloon, although we certainly think that given the size that Dr. Lauer saw on the IVUS intravascular ultrasound, that we're going to have to go in there with at least a 3.5 millimeter balloon to really get that stent adequately expanded into the wall.
So we've already prepped a balloon 3.5 millimeters by 15 millimeters long. The stent, as you will recall, is 28 millimeters. And we're going to try to stay exactly within the margins of the stent which we have deployed. Very important to do that. The area of highest narrowing is at or just beyond the margins of the stent.
Yeah, I think in the United States trial, where we didn't have all the stent lengths available, and we didn't know if we were putting in a drug stent or a bare one, there was a fair amount of ballooning around the stents, and we saw about 5% of the patients had blockage outside the stent. And so now, having learned from that, the European trial, using a very similar protocol, had about a 1 or 2% blockage outside the stent, which is extremely low and much better than a bare stent, actually. So as long as we keep our injury with the balloon inside the drug, I kind of liken it to suntan lotion. This is one of my favorite analogies. If you put suntan lotion on your back but not your neck, and you lay out in the Bahamas for about 4 hours on your stomach, and you get sunburned on your neck, it's not because the suntan lotion didn't work. It's because you injured an area that wasn't covered with the drug or with the suntan lotion. And the same holds true with this stent. If you do a lot of injury to the blood vessel where there's no drug, you certainly can expect to have some reblockage there. That looks like a good position there, Bill.
Okay, let's take her up. Take it to 12 atmospheres. 14. 16.
That looks terrific.
Okay, try 18 and down.
I have a couple of other questions that have come in I'm going to try to address while you're dilating the stent there, Bill. Someone emailed in a question, can you remove an old stent to put in a new one? And that's actually a pretty good question. The answer is we can't really remove the old stent if it's reblocked. What we do, though, is we clean them out, stretch them open, and there's a trial going on and some early trials where we put the drug stent inside a blocked old stent. We call that a stent sandwich. And by doing that, we deliver the drug to the blockage within the old stent, and that seems to be quite effective. One of the other techniques to use in that situation is radiation therapy, which we have done quite a bit at Borges. But I think the drug-eluting stent is probably going to replace that.
I think what people need to realize, Tim, is that when we say the numbers that Dr. Campbell shouted out here, 12, 16, 18 atmospheres of pressure, that's about 5 to 10 times the pressure in your car tires. And we saw that it took fairly high pressure before that waste went away, because there's a fair amount of calcium in that artery. So these are high pressure, and that stent gets pushed into the artery wall at high pressures and really becomes part of the wall.
It was very reassuring, though, to know that this vessel was close to 4 millimeters, which gave, I think, Dr. Campbell a little bit of liberty there to go to pretty high pressures with that 3.5 millimeter balloon. Without the intravascular ultrasound, I'm not sure he would have wanted to take it quite that high, but I think he's pretty comfortable. Is that fair, Bill?
That's very fair, yes. Okay, we've inflated the balloon twice within the stent. I inflated it distally and then pulled it back and inflated it a little more proximally, staying within the margins of the stent. We've removed the balloon. We're now going to take a picture.
Wow.
And As you can see, the vessel is widely patent.
This is exactly the kind of implant that we like to see. You can see that's a great, just pause there, you see what we call a step up at the proximal or the front end of the stent, where the vessel actually looks like it gets bigger. You can see where the stent edge is. And then we like to see what's called a step down as you leave the stent and go into the next part of the vessel, a step down. When you see that appearance of the stent sort of bulging a little bit bigger than the vessel itself, that's a sign of a very good implantation. It means that the metal is driven well up into the wall of the blood vessel. The risk of the stent clotting or reblocking at this point is extremely low. That's an excellent result.
So we have now removed the balloon. We're going to put the intravascular ultrasound back down the vessel.
Okay. Can we loop the angiogram? Just let that loop so the audience can see the angiogram a couple of times, be looped in real time.
That last picture, please.
The last picture, just replay it, let it loop. I want the audience to get a sense of just how big we made that area that was blocked by putting that stent in. And that side branch that was just past the blockage is still there. We always worry a little bit about pushing some of the plaque into that little branch, but in this case, we didn't. We see a very good result at both ends of the stent. I'm going to answer a couple of other questions that I've gotten. A good question: how much drug gets released? How does it relate to a 5-year follow-up? How does the stent give off this pharmaceutical agent? And the answer is that the drug is incorporated into a very, very thin layer of polymer or plastic that's on the outside of the stent. And that drug that's contained is covered with another thin layer of polymer that slows what's called the elution. So the drug wants to sort of move from high concentration to low concentration by diffusion. The polymer that's put over the top of it sort of slows that process down so that the drug is released over about a 30 to 60 day period, exactly the time period when scar tissue is forming after the injury to the vessel from the stent. So what we want to do is match the drug release to the time course of scar tissue formation after the injury from the stent.
Polymers are actually quite amazing in the way that they deliver the drug itself. You don't realize there are people out there that just design polymers for such usage. I'm now advancing the IVUS down through the stent and just beyond. And we'll now go back to Dr. Lauer, who's going to show us the final results.
Okay, now we're, if we can go to the full screen IVUS, we'll see that we're now distal once again to the stent. We're going to start our pullback, and here we have some moderate disease distal to the area that we've stented.
By distal you mean downstream.
That's correct. And now we see coming into view is these bright bands of the stent here surrounding the large lumen now and pushing this plaque back against the arterial wall. We continue to pull back and see the stent struts surrounding. We see this large lumen. We'll come back shortly to the area that was severely stenosed around, if you recall, around the IVUS camera. And now instead of narrowing down, we've still got a 3.5 millimeter lumen all the way through. We're slowly pulling back at a 0.5 millimeter a second through this area. And it looks like the stent is well opposed. And you see that the stent struts are up against tissue in every plane.
Yeah.
What we don't want is these bright stent struts floating out in the stream, because that would be a setup for thrombosis. Blood could clot on those stent struts if they were not firmly opposed and pushed into the artery wall.
Well, I'm particularly happy with that, the top part of the stent there that, as you point out, even in that almost 4 millimeter area, by going to such high pressure with that balloon, I think Dr. Campbell did a great job getting the entire stent really perfectly conforming and embedded into the wall of the blood vessel. So that's very reassuring. I think that's a great result. The opening that was barely the size of the camera at 1 millimeter when we started is now almost 3.5 millimeters in diameter. Is that fair to say?
Absolutely. Right here, right about in looking in the long axis now, we can see the stent struts here below the camera and above the camera, pushing that plaque back, and you see a wide open tube. I'll place our cursor right at the area that corresponded to the most severe area, and right about here, about 2/3 of the way down our screen, and you can see we'll take some quick measurements here. Now in the vessel, which is still out, there's still some plaque. That's why we didn't take the artery all the way up to 4 millimeters. We had to leave some room for that atherosclerotic material to be pushed back and contained. But now if we make some quick measurements, we see that in this artery that's 4.8 by 4.3, we have a lumen that's 3.5 by 3.2, where it was 1.2 by 1.7 before. So with lumens this size, there's a very good chance this is going to stay open and should provide the symptomatic relief that he needs to get back to the lakeshore.
So the area is now gone from what, about 2 millimeters squared to almost 9.
That's right.
Is that correct, Mike?
That's right. It was 2.5, I believe. I can just flip back. If we're still live on the full screen IVUS, I'll just
refresh our memory. This was a pretty tight blockage at 2.5 millimeters squared of cross-sectional area, and now we're at about 8.7. So we've gone up almost by a factor of 4, 3 or 4 in terms of the area of the vessel to carry blood to the heart muscle, which is going to correlate very well with relieving this fellow's symptoms, I believe.
Absolutely. This is the pre, once again, if you've got full screen on the IVUS.
Yes.
And then quickly going back to the post, it's a great result. I think we've covered that distal area very well as well. We've got the entire lesion covered.
That's a very nice result. Bill, can we go live to you and maybe you're going to pull that wire out and show us the final picture? Is that your plan? And I think you're just about done here.
Yes, we are.
You made it look pretty darn easy, Bill.
Pulling the wire out, pulling the IVUS out, and we'll set up for the final picture here. We are quite pleased with the results. He should be able to walk his dog on the lakeshore without any discomfort. So we've got the catheter in, just taking our final picture. And
That's
again,
a great
the
result.
vessel looks very good.
Fantastic. Good job, Bill, and Mike, and Dr. Solomon, and the team, Kim, and everyone else in there. That's a great result. There, there's the picture right there. Picture's worth 1,000 words, and that is a great result. We're going to cut back and just wrap up now with a couple of final comments that I have. I had a couple of quick questions that I will answer. Someone asked, is all of the embedded drug released from the stent? And the answer is that the drug is completely gone within about 2 months. And so the vessel typically takes 3 or 4 months to heal. The drug's gone in 2 months, and there's no residual drug left. Borges was very involved in the clinical trials of this, and we remain involved. We actually are currently in 3 of the investigational trials that are testing this product in a variety of other situations to see whether it works in other more difficult, more complex disease and anatomy. Why don't we go to the PowerPoint and show just a couple of additional slides just to finish up. This is the longest follow-up that we have of any of our patients that were treated at Borges. This is a patient, a diabetic, who had a long area blockage in the left artery. And you can see in the middle angiogram a very good immediate result. This patient didn't come in for his 8-month picture, but came in at 18 months and let us take a picture. And you can see in this diabetic with 3.5, almost 4 centimeters, 2.5 inches of stent placed in his left artery at 18 months follow-up, both by the intravascular ultrasound on the right and the angiogram in the bottom left. You can see essentially no blockage. So I think this has been well summarized in a couple of quotes, and I'm going to finish with these quotes. One from a very respected professor of cardiology from Europe, Dr. Patrick Sorois, who recently said that, in my opinion, in less than 5 years from now, all stents implanted will be drug-eluting stents, and that the current bare stents, or the stents currently used, will be considered prehistoric tools. Well, I think that day for the U.S. and for the U.S. patients is essentially here today. Another very important quote, I think, from a recent Wall Street Journal article from Dr. Mishkal, who I think summarized it best for me as a practicing interventional cardiologist when he said, ultimately, You know, it's the mother's test. We have patients who come in and ask, what would you want your mother to have? And he says there isn't a cardiologist out there who wouldn't want their mother to have the coated stent every darn time. So I think that summarizes my thoughts about this device, that it really is going to help patients, that it really is going to change the face of what we do every day. And I think you've seen a very nice live demonstration that this is a relatively simple technology. The patient here is going to be able to go home tomorrow morning and go out there and run and jog and walk and feel good and know that his chance of having that stent reblock is in the range of 1 in 100. So if there are no other comments, I think we're going to conclude our webcast. Thank the crew who did a terrific job setting this up. Thank Borges, and we're gonna say, please take the CME evaluation. Please click the button on the player window, and you can get CME credit as well. So I have just been given my final note, and with that, we're going to say goodbye from Borges Medical Center, and thanks everyone for tuning in and paying attention. Have a good day.
You have just seen a live cipher stent procedure hosted by Dr. Fischel and performed by Dr. Campbell with the assistance of Dr. Lauer from Borges Medical Center in Kalamazoo, Michigan. For more information on the cipher stent procedure or Borges Medical Center, please contact us by clicking the link on the player window below, or call us at 269-226-8135 or toll free at 1-800-828-8135.